morning, everyone. Thank you for the introduction. As Dr. Black said, I'm Andrew Gillooly. I'm the second year ASTS fellow here at VGH. I've been here about 18 months. Very excited to be here. Coming from the United States, especially now in sort of the political landscape, it's kind of nice being here, where everything's a little bit more calm and a little bit more steady. But I decided to talk to you guys this morning about normothermic regional perfusion, which is a technique that's becoming more and more ubiquitous, especially in North America, in recovering organs from patients that become donors after cardiac death, which was traditionally a smaller pool of our donors. So anything that really increases the numbers of available organs for transplantation is an overall good thing. And it's something that I've become, thankfully, more experienced with here in my fellowship as we've started our own normothermic regional perfusion program within the last year here at VGH. So I have no disclosures. I'm just a lowly fellow. So the objectives of my talk today are basically fivefold. The first is to review the different types of deceased donor organs that become available to us, with emphasis on the need to find solutions to improve organ quality from those that are available, specifically in the realm of donation after circulatory death, which is a pretty specific donor criteria. Explain the role and how normothermic regional perfusion as a technique actually works as an adjunct to DCD donation. Then I'll discuss the outcomes of NRP, specifically on liver and kidney recipients. It might be a little bit more on the liver-heavy talk, but there is some data and information available about how this affects kidney transplants as well. Understand some of the controversies that surround the use of NRP, especially as we use it more and more, and then understanding the next steps in utilizing NRP in a place like British Columbia or Canada nationwide. So just to start with some interesting statistics from BC Transplant. BC Transplant as an organization, I think, does a very good job in outreaching to the community as a whole in order to increase the amount of available donors. I think they're also a very transparent organization, at least in my experience. They do a very good job in terms of things like social media and having like an online presence about what the actual donation process is like in British Columbia. In terms of the numbers that we see, the most available data from BC Transplant is from 2024. I expect the 2025 data will become available within the next several months. That shows in British Columbia, 118 deceased donations happened. That's a combination of donors that die after circulatory death and after neurological death combined. And then the NRP sort of pathway down after DCD aims to increase the available organs from DCD donations specifically. And hopefully over time, as NRP becomes more utilized here in BC, we can even increase the amount of organs we're taking from every DCD donor. But first, what exactly is a DCD donor? So it's a very specific pathway, like I said, in terms of patients that have died and have come forward or their families have offered them forward to become organ donors. They're cadaveric, which means they are deceased. The donor is someone that has suffered an unrecoverable brain injury but does not meet the full criteria for brain death or legal death, which would be a DNC donor. These are people that are usually identified in the ICU after they've had their terrible injury. When it's determined that they're not going to have an acceptable quality or quantity of life, the family is usually approached by a BC Transplant, at which point conversations are had about whether the person's a suitable donor. Because they don't meet the criteria for brain death, though, we do have to wait for their heart to stop in order to collect their organs. So death for DCD occurs via, as I said, the heart actually stopping when life-supporting measures such as pressors or intubation and ventilation are withdrawn. After a 5-minute period where the patient has actually been deceased, then they're rapidly taken to the operating room, prepped and draped. The abdomen is opened, the aorta is cannulated, rapidly flushed. The organs are cooled, and then we can move forward with removing the organs and transplanting as we normally would. The fundamental difference between DCD and NDD donors is around the concept of a warm ischemic time. So when a patient is dead by neurological criteria and they're determined to be a donor and consent is obtained, we can take that donor to the operating room and we can perform like an elective surgery. We can open up the abdomen in short order. We can put the cannulas in, all the while the patient's being mechanically ventilated, their blood pressure is being supported, they're getting blood transfusions as needed. When everyone's ready, including the abdominal or thoracic team if they're present, then the organs are rapidly flushed with cold preservation solution. and the abdomen and chest are packed to cool the organs, at which point we can then remove them and take them back home. As opposed to the DCD, as I just alluded to, we have a little bit more of a complicated process. We have to wait for the life-supporting measurements to be withdrawn, asystole to actually occur, the 5-minute handoff period where we ensure that the patient is actually deceased, then the rush to the OR, then opening up the abdomen, and then flushing. And it's specifically in that time between extubation, asystole, and that 5-minute handoff period that we have the most variability in what we're able to do with the donors. In an ideal situation, the patient rapidly expires. We're able to get them to the operating room and get the organs flushed very, very quickly. However, as is the real world, that doesn't often happen. Sometimes the patients undergo extubation and their life-supporting measures are withdrawn, and they can take minutes to even up to a couple of hours to actually pass away. And unfortunately, in some situations, they don't pass away within an allotted time frame, usually 2 hours, at which point the donation is canceled and transplantation cannot occur. The period between extubation or withdrawal of life-supporting care and asystole is also marked by hemodynamic instability. The patient's heart may still be beating, but their blood pressure may not be suitable or adequate to adequately perfuse their abdominal organs like their liver and their kidney, at which point the worst kind of ischemia occurs, which is the warm ischemic insult to the organs. So toxins and metabolic waste products are building up in the organ. They're not adequately being flushed out. In addition to that, there's oxidative stresses, because as you can imagine, the patient probably isn't breathing, they're probably agonal, and oxygen isn't perfusing their organs appropriately, in which case they're becoming more and more damaged with every passing second and minute, as opposed to in an NDD circumstance where everything is perfused right up to the point we cross-clamp and flush. So in addition to the warm ischemic time, that's a very variable factor for every DCD donor. There's also the standard cold ischemic time that we'd see in an NDD donor, and then the warm ischemic time in that the liver or the kidney or whatever organ you're transplanting comes out of the cold and then is actually being sewn in, but the surrounding tissue and the recipient is warm. So there's some degree of warm ischemic insult there. So as you can see with DCD, you add this sort of long period of warm ischemia, which is actually the worst kind of ischemia to have for an organ. DCD donation across North America as a whole is thankfully something that is increasing with time. On the left here is some information from Canada specifically. So since 2008, DCD donation has been performed in British Columbia. DCD donors are becoming an increasing source of organs. In 2024, 41 of those 118 that we talked about a few slides ago were from deceased donors that were through the DCD pathway, and then 56, looking at the information across Canada as a whole, came from DCD donors, which I think is pretty remarkable. And I think that's the first time, at least in the recorded data I could see for the last 10 to 15 years, that more donors were DCD than DND. Conversely, on the opposite side, the United States where I'm from, DCD liver utilization specifically is becoming more and more ubiquitous over the same time period. It's still a relatively small proportion of donors. You can see these sort of small gray boxes here, but over time the trend is clearly going up. And as we use things like normothermic regional perfusion, which we'll get to in a few minutes, I only anticipate that that's going to increase. So what factors specifically influence the outcomes of DCD donation? DCD donation requires careful donor and recipient matching to optimize results and safety for the recipient that gets whatever organ you're taking. Donor factors for DCD donors include their age, their physiologic stability, and the kind of injuries that they sustained from their trauma or their fall or whatever brought them to the end of their life, their weight and their size, the location of where withdrawal of life-supporting therapy is actually a big deal. As I've learned across BC, where we've been doing these DCD donors, where the ICU is in relation to the operating room is actually a big deal. If you have an ICU that's far away from the operating room and you withdraw care from a DCD donor and they pass away, you have that 5-minute waiting period, but then you're also adding on minutes of transit time from wherever they are in the ICU or the PACU to the operating room. And if you're coming down to the wire in terms of how long you have until you can cannulate and take the organs out of a DCD donor, that can add 2 to 3 minutes or 4 to 5 minutes to your time, and it could even time out the organs so that they're not available for your transplant. The functional warm ischemia time we already talked about, pre-arrest anticoagulation, which makes things very bloody when we do a DCD donor because we're rapidly cutting through tissue. We're not doing things with like bovine, and then this cold ischemic time, how long it's going to take to get the organs out and then back to home base before you actually transplant them. Conversely, on the recipient side of things, age is a big factor, especially for liver patients. Their MELD score, the acuity of their illness, what caused their liver disease, and how sick they are. If someone has a very high MELD and is critically ill in the ICU, you probably don't want to give them a older DCD donor that had a relatively long warm ischemic time after they were extubated, because we know just based on our own experiences that DCD donors lead to more rocky actual transplantation, but also their postoperative care too. So ideally you would have a younger DCD donor that dies quickly that you can put into a relatively healthy recipient, but sometimes that doesn't always work out the way you want it to. Mm-hmm. So that is technically possible. I think it's hospital specific, and the reason I say that is because I've been to probably around 10 hospitals throughout British Columbia, and it's different where we actually do the withdrawal. Most of the time it's in the ICU. I think that's mostly a social issue so that family can be present when the patient actually expires. Other hospitals will let us do it in PACU, so it's at least a little bit closer. And then sort of like a very specific DCD donor thing would be like MAID donors, so patients that have elected to end their life but also want to be organ donors. That's another situation where they're basically DCD because they get a big drug bolus before they actually pass away, and a lot of times those can be done in PACU. So I think it's hospital specific. I don't think there's like one generalized sort of guideline that says it can happen in the operating room. That being said, for VGH, when we do our NRPs, just because it's such a resource intensive thing, that gets done in the operating room. But we'll get to that in a few minutes. So what's the problem with DCD organs? So we'll go through it sort of on two sort of sides of things. We'll go through it from the liver side and then the kidney side. From the liver side, DCD livers we know have overall lower graft survival. They have higher rates of early allograft dysfunction after initial transplant. They have higher rates of primary non-function, which means the liver never works as soon as you plug it in. Up to 12% for DCD organs is not insignificant, and that's an especially morbid condition to be in because we've taken out your old liver, put in a new one that's not working. The only recourse is to emergently relist the patient for transplant and hope that they make it and survive long enough to get another organ offer, which certainly isn't a guarantee. The dreaded complication of DCD livers is the biliary complications, including ischemic cholangiopathy. So the liver, particularly the bile ducts in the biliary system, are especially sensitive to ischemic changes and hypotension. So that period where a DCD organ may not be perfused after extubation can really lead to terrible outcomes from a biliary side of things. Patients are often dealing with things like ischemic strictures that have to be serially dilated or stented. And then over time, they can actually end up with ischemic cholangiopathy that causes loss of the graft, and they might need to be retransplanted down the line. DCD liver transplants, like we just said, are also associated with big hemodynamic changes. So when the old liver comes out and the new one comes in, and we're ready to reperfuse, we have to have very, very good communication with our anesthesia team. Post-reperfusion syndrome is a very real phenomenon that can happen. When we undo our clamps, even if we flush the liver out and remove all the preservation solution that we possibly can, the sudden bolus of cold blood and any of the toxins or free radicals or things that have built up in the liver as it's been out of the body get bolused directly into the heart. So it's not unheard of for patients to become profoundly bradycardic, go into arrhythmias, PEA arrest. And at least once of the 60 or so liver transplants I've been a part of, I've had to do CPR on patients that have had reperfusion syndrome to the point where they code. So you need clear communication and excellent resuscitative efforts with an anesthesia team that you trust, because these patients can have a very rocky course, starting from the time you're taking their old liver out and putting the new one in, all the way through their ICU stay and their immediate postoperative recovery. DCD organs on the kidney side of things, it's a little less dramatic, but there's still increased rates of delayed graft function, which is usually defined as the need for dialysis within a week after a transplantation. DCD organs are also associated with increased risk of discarding the kidneys because we don't think that they're adequate for transplant when they may be. We just don't want to take the risk. It's associated with increased patient morbidity as well as the overall financial cost to the hospital institution because as you can imagine, if patients are stuck in the hospital requiring dialysis or have other complications from their surgery, then the cost to the healthcare system increases over time. And this is just a study out of University of Cambridge. It's a little bit older, but I think it just goes to show very specifically that there's statistical differences in DGF between patients that get DCD and DND organs, as well as their overall 5-year survival compared to those that had kidney transplants after neurologic death donation. So a little bit more about the actual DCD recovery technique. It's called super rapid. It occurs after the 5-minute waiting period when the patient's actually expired. We make a very long midline incision, basically from the notch of the manubrium all the way down to the pubis. Usually do it with a knife to get through the subcutaneous tissue very, very quickly. After that's done, we reflect the bowel medially, usually to the patient's left. We find the retroperitoneum, try to palpate the aorta, open up the tissue over the aorta, encircle it very quickly, tie off the legs, and then insert a large bore cannula into the aorta and start cold flushing with preservation solution as quick as we can. Usually we try to do this as quick as we possibly can, usually between 3 to 5 minutes from the time the patient comes into the room. Following perfusion through the aorta, we pack the abdomen with ice to get the organs down as close as we can to 0 degrees, and then we work quickly to remove the organs and get them back to base, because we know the longer that you try to take the organs out of the donor body, they're accruing more and more warm time, because even with cold preservation solution and ice, eventually those organs are going to warm up. There's an increased risk of organ injury, especially as you're passing along big knives and slashing down very quickly through the abdominal tissue and chest wall tissue. I myself have caused a few injuries specifically to the liver. It's very anterior, and as you're coming through this tissue, it's very easy to come through and either get like a nick to the left or the right lobe of the liver. It's also easy to damage things like the stomach. And then thankfully I haven't, but it's always possible to cause an enterotomy, in which case you've contaminated all the organs. It's very, very easy as things are going rapidly and trying to get those cannulas in, that you can actually hurt the organs you're trying to procure. So how can we improve DCD outcomes? The first is looking at statistics and looking at how things are going before the actual donation. So optimizing the retrieval process, things like where do we actually do the extubation withdrawal of care, having strict donor acceptance criteria, and matching them with our recipients effectively. And then during the actual retrieval, how could we increase the oxygenation and increase the blood supply to the organs, in which case NRP comes into play. So NRP becomes an adjunct to the DCD pathway. Patients are still dying after circulatory death, but we're adding the technology and the procedural sort of realm of NRP to increase the ability of us to assess and then ultimately take the organs. So NRP as an overall sort of idea has been around for probably, I'd say, the last like 25 to 30 years. When we decided that it would probably be better, instead of just having a liver or a kidney in ice on cold static storage, to hook it up to some sort of circulation pump. That's been going on for years and years, even before transplantation really became a clinical standard. But within like the 15 to 20 or so year period, using things like ECMO as the circuit to potentially perfuse organs happened in the early 2000s, and then moving through specifically in the UK and the European community, where NRP is becoming like sort of the gold standard, or has been the gold standard. They're actually utilizing it in all of their DCD donors, which I think is pretty remarkable. And that started within the last year. So there's two main types of NRP, abdominal versus thoracic. This talk mostly has to do with the abdominal NRP sort of things, because I am the abdominal transplant fellow. But there's also an adjunct called thoracoabdominal NRP, in which case you can actually cannulate and prepare to take the thoracic organs as well. And the benefit for at least thoracoabdominal NRP is that after the patient's expired, you can rapidly reestablish warm oxygenated blood flow, not only to the abdominal organs, but also to the chest and to the heart, in which case they can actually see how the heart's functioning and beating in real time and decide whether they want to take it. For our intents and purposes, we focus more on this abdominal NRP, which is basically isolating the abdominal organs from the diaphragm to the pelvis and putting them on an ECMO perfusion circuit to perfuse them.
imagine both have to happen quickly.
Yes.
Can you do both?
Yeah, so the benefit of doing like thoracoabdominal NRP is basically like you prioritize getting the heart and the lungs perfused, but by the wayside, you can perfuse the abdominal organs just as easily because they cannulate the descending aorta and all that preservation solution can, or the ECMO, not preservation solution, but the ECMO circuit can perfuse the abdominal organs sort of as like an adjunct or as a bystander, as opposed to abdominal NRP where you're specifically just isolating the abdominal organs. And that becomes important for a lot of ethical reasons, which we get to at the end. So abdominal NRP, much like the regular DCD profile, follows asystole in the 5-minute standoff period. For VGH and per our protocol, the patient's already in the operating room. They've passed away, the family's already said goodbye, and then they're quickly escorted out. After the 5-minute waiting period, the abdomen is prepped and draped. We open up through a midline, and then very similar to a regular DCD donation, we move the abdominal, like the viscera out of the way. We place a cannula in the aorta, and then in addition, a cannula in the IVC. And that creates a closed circuit with inflow and outflow to the ECMO machine. At the same time, our thoracic team is doing a sternotomy and cross-clamping the thoracic aorta. And by cross-clamping the thoracic aorta above the diaphragm, you've basically isolated the abdominal organs on a machine. So nothing's going through the aorta up to the lungs or coming down from the lungs and the heart. And everything's going through just basically this block in the abdomen. Once we've established flow on the ECMO circuit, we also do a couple of other things. We place basically an A-line cannula through the inferior mesenteric artery and pass it off to the anesthesia team. That lets them measure the perfusion pressure in the intestines, and as an adjunct, we know that the kidneys and the liver are getting good flow too. We also identify and divide the bile duct, and then usually put a small bore feeding tube into the bile duct and collect bile over time as the liver perfuses. The big thing for this is we try not to do a lot of sharp dissection, because if you have any raw surfaces after you've reestablished flow on an ECMO circuit, you can imagine everything just bleeds. And over time, if you're going to perfuse the liver or the kidneys for 1.5 to 2 hours, that bleeding can really accumulate and require more and more blood transfusion into the circuit itself to maintain pressure and flow. One of the benefits of NRP, I think one of the major benefits of NRP, is the fact that because the organs are now perfused and we have a circulating blood supply, we can test that blood for things like lactate clearance. We can look at LFTs. We can look at blood gas, and we can determine how these organs are functioning while they're still in the body of the deceased donor. For liver, that's kind of a game changer. With a traditional DCD donor, you kind of have to see how the donation played out, how the patient became hypotensive over time, see if you actually got your cannulas in, usually within a 30 to 35 minute window, and then actually see and visually inspect the liver, plus minus a biopsy, to determine if you want to keep it. With NRP, you do sort of a similar thing, put the cannulas in, start the perfusion circuit, and then with these real-time analyses, looking at blood or blood gas, lactate, you can see how the liver is actually functioning in real time. If you find that the lactate's very high, 12 to 14 from the patient being agonal and dying, and then you hook them up to the ECMO circuit and the liver starts clearing lactate rapidly, it starts producing bile, the LFTs start normalizing, you'd know that this is probably going to be a good liver. Conversely, if the lactate doesn't clear, the liver doesn't make bile, you're concerned with how it looks, you biopsy the liver and it's got some degree of hepatitis or fibrosis, then you don't accept the liver. And you haven't put your recipient through a very rocky reperfusion phase, a very rocky transplant, and then haven't subjected them to the complications of things like ischemic cholangiopathy down the line. So you don't really lose much, you just have a lot to gain. After the perfusion period on the ECMO circuit stops, usually about, like I said, 2 to 3 hours, then you just simply replace the blood circulating through the ECMO circuit with our normal ice-cold preservation solution, pack the abdomen in with ice like you normally would, and then proceed with removing the organs. So the benefits of NRP, we've already talked about them a little bit, but increasing the organ acceptance from DCD. So if a donor looks particularly bad on paper, he might say, oh, I'm not even going to entertain the thought of this liver. It looks fatty on the imaging. The patient has a history of alcohol use. It looks nodular, like there potentially could be some cirrhosis. I'm not even going to consider it for one of my recipients on the list. However, with NRP, you have the benefit of saying, hey, I'm going to go do this DCD anyway. We might as well put them on NRP and see what the liver does. If that's the case, then you've expanded how many donors are potentially available to your list. The viability and testing we talked about, just so you can see in real time how the organs are functioning. All the abdominal organs from diaphragm to the pelvis are affected. So it's one simple intervention that has a pretty big change in the outcomes for everything in the abdomen. It's a lot less unhurried. Once you get those cannulas in and you've established the flow to the organs, you kind of sit back and relax over that 2-hour period and see how things go before you have to flush and take the organs out. If that's the case, then it's almost like when you remove the organs proceeding with a DND donor, because you've had a little bit of time and you know that these livers or these kidneys are actually going to work. And then finally, you've reduced the ischemic injury and stress to the organs because the ECMO circuit is providing oxygenated blood. So starting in Europe, where NRP has been more ubiquitous and they have a much more broad understanding and utility of this sort of technology. Out of the UK in 2022, they looked at 163 of their own NRP cases. They noticed that specifically for kidney, liver, and pancreas, that the NRP significantly increased the rate of how often that they would take an organ from a DCD donation by a factor of 1.5. So somewhere between 1 and 2, doubling the amount of organs from DCD donation is pretty remarkable. And then they noted that post-transplant failure is lower in NRP, including specifically for kidneys, delayed graft function. In North America, the benefits are very similar. Johns Hopkins published a retrospective study in 2024 that looked at DCDs, sort of the classic pathway versus NRP. Theirs was thoracoabdominal. For kidney transplants between 2020 and 2022, they identified over 16,000 transplants through UNOS, which is the United Network of Organ Sharing. It's the database that the American system uses to keep track of their transplants as well as their outcome. 306 of those 16,000 were done using thoracoabdominal NRP. As you can imagine, the degree of delayed graft function, which was the need for HD in the first 7 days after transplant, as well as overall post-transplant survival and all-cause graft failure, was significantly reduced for patients that had undergone NRP. There was no difference in the graft failure rate at 180 days, so several months after transplant. The caveat being that, at least for the NRP donors that Johns Hopkins looked at, they tended to be younger donors and had lower KDPI scores, which are the risk scores that we use to determine how good a kidney is going to be for a particular recipient. So it could have been a little bit biased that way, but I think overall it's very clear that NRP certainly is helping and it doesn't appear to be doing harm. And then over here, this graph on the right again just sort of demonstrates that more and more DCD and NRP cases are happening every year in North America, and it's pretty dramatic, even over the course of the last 2 to 5 years. Looking at abdominal NRP, another good review came out of 17 transplant centers in the U.S. just within the last year. They looked at specifically for liver transplant recipients, 136 livers that were recovered after DCD and NRP. 106 of those had gotten perfused with the ECMO circuit. And then the big thing, and perhaps not unsurprisingly, the degree of ischemic cholangiopathy, which is our big complication after DCD liver transplant, primary non-function, early allograft dysfunction, biliary strictures, length of stay, patient and graft survival were all their endpoints. And then I think it's pretty cool that at least for the patients that underwent NRP, there were no reported cases of primary non-function versus 2 in the patients that just had a DCD super rapid recovery. And then there's significantly lower rates of ischemic cholangiopathy after the NRP perfusion. And overall, the graft and patient survival is relatively the same. But this is huge, at least for patients that receive DCD liver transplants, because we're significantly reducing their post-operative care. They don't have to come in for ERCP every 6 weeks to get stent exchanges and balloon dilatations of their bile duct, or God forbid that they need another liver transplant down the way. That's very, very good. So what are the downsides of NRP? The first is probably the financial cost. So as opposed to just a DCD where you need an abdominal organ team, including surgeons, as well as someone from BC Transplant to help organize and get the operating room set up, nurses, etc., much like a regular OR case. If you add on NRP, now you're talking about requiring the equipment to do it. You need an ECMO and pump circuit, including all the single-use plastic associated with that. You need a perfusionist to help run the machine and to keep track of the pressure, as well as the labs while the NRP is actually ongoing. There's a blood cost to the blood bank. Over time, inevitably, you lose blood in the circuit from bleeding in the patient, whether it's in the abdomen or the chest, that has to be repleted with transfusions. At VGH, for our NRP protocol, we can transfuse up to 8 units before we have to stop the perfusion and flush the organs. The OR time, so that 2-hour period after you've cannulated and everyone's just sort of hanging around and watching and seeing what the liver and the rest of the organs are doing, is just time that is accruing in terms of the cost for the hospital to have to pay for. And then all of the lab tests, the point of care tests that happen in real time during the NRP perfusion, all of that adds up specifically too. In the United States, I couldn't find any data from Canada because only 2 centers are doing it and haven't published much about it, but $6,000 to $4,000 additional US dollars on top of what is already fairly pricey to the healthcare system. I can almost imagine a situation where if this becomes more and more ubiquitous, we're going to have to find a way to become very, very efficient with how we do this because, for example, it costs enough just to fly a donor team out to Kamloops or Kelowna to recover organs. But if we're going to start doing NRP across the province, the options are either taking a team with us with things like an ECMO circuit, a perfusionist, adding all those extra costs on top of a team flying out, or finding a solution where we have DCD donation potential, and then we bring them all to VGH and just do everything at VGH, which I think is probably where we're going to end up going. But you can imagine there's significant costs in transplant or transporting a patient that has ICU level care needs from all over the province to Vancouver, and it's kind of a big ask for a family to say, hey, your family member's dying, they want to be an organ donor, could you say goodbye now, and then we're just going to take them away.
Has anyone looked at the net cost though? Because from what you're showing before, like the people who have problems, repeat livers, ICU, stent exchange, like, I mean, obviously this is a lot of money, but not if you look at the grand scheme of taking care of someone who liver has DGF or whatever else. So
yeah, I guess it's kind of like, how do you want to take the hit? Do you want to bleed out right away and spend a lot of money right away, or do you want to eat that cost over time and accept that there's more things like complications that you have to manage, inpatient hospital stays, infections? I know, traditionally for things like kidney transplantation, the costs of doing a kidney transplant are very high up front, but the cost savings of keeping someone off dialysis, which itself is its own expensive therapy over time, it's no comparison. It's much cheaper to do a transplant than it is to deal with the complications of dialysis for years and years and years. So I can imagine it's going to be a similar situation. But yeah, it's going to be, do you just pay the upfront costs associated with this and accept that it's going to be better in the long run? As far as I can tell, no. But I can imagine it's probably going to be a similar thing, that we save money in the long run by spending a little bit more money up front.
The alternative being transmedics and other technologies.
Yeah.
So they're in the US, they're looking at NRP as the cost-saving measure.
Exactly.
Rather than comparing it to DCD.
Yeah. At least for things like organ pumps, which is what we're talking about with things like transmedics, it's all proprietary technology. So if you're going to use like an organ pump that pumps the organ outside of the body, then a lot of these companies require you not only to use their own equipment, but they have their own technicians that they say have to be utilized. Those are all costs that, again, have to be accrued by someone. I think ultimately NRP is going to be a cheaper option, but at least right now it is more expensive than sort of the traditional DCD path.
Andrew, quick question. In BC, do you right here? Thanks. 2 questions. One is, in BC, do you get a sense of what proportion of DCD patients are outside of the Lower Mainland? And the second follow-up question to that is that instead of patients coming to VGH, is there a downside to having regional centers? Because what you need is a cardiac surgical team, aka perfusionist and ECMO pump. So you could even be a regionalized DCD, places like Kelowna, RCH, like Victoria or something.
Yeah, anecdotally, I would say maybe like half of the organs that we go out for, it feels like are DCD. And that's all over the province, like outside the Lower Mainland. I think it would be challenging to have like a local NRP program at each hospital, but like you said, maybe one in Kelowna, maybe one in Kamloops. Prince George is the farthest I've ever gone in terms of going to retrieve organs. But again, I think at least for us in Canada, NRP is still very much in its infancy. And getting the program to go at VGH is the first main step before we determine how we can best utilize this resource in other hospitals and whether it can be, can we train people to do this at these smaller community hospitals just so that we don't necessarily need to bring everyone to VGH. At the American Society of Transplant Surgeon conference last year in January, there was a lot of good talks about this, and at least in the United States, when programs were starting NRP, in order to go to these smaller community hospitals, they were actually taking everything with them.
Yeah.
And they found that that was just logistically easier than trying to have a bunch of smaller centers that were well equipped enough to do this. For smaller hospitals, like the amount of organ donation, regardless of DCD, DNC, that they actually do can be very low. So sometimes you go to a hospital and the teams are like feverishly going through the procurement book because they haven't done an organ procurement in months to years, right? So I think at least what I could see is that it would probably be a bit easier to take the stuff with you. But again, that's a huge logistic and cost barrier.
Yeah, because I find people are easier to transport, but it's,
Yes.
I'm assuming the equipment that's not, right?
Yeah. I mean, it's tough enough loading all the equipment we bring. You can see sort of in the background here, that little cart. All the stuff's already been loaded into the plane, but it's, bags of ice, coolers for the organs, all the plastic equipment we need that we don't rely on the other hospital to have. And now you're going to try to do like an ECMO pump too. We need bigger planes. So logistically, like we just talked about, do you move the donor to home base like VGH, or do you bring the NRP team with you to the other hospital, including all the equipment and supplies you might need? Consent. So this is a big thing. Approaching a family to undergo organ donation is challenging enough. Now we add this sort of extra layer of NRP. What do you disclose to the patient's family? Do you disclose everything? Do you say, hey, the patient's going to actually expire, and then we're going to put cannulas in your loved one's blood vessels, and then go to, like, for the lack of a better term, reanimate their abdominal organs, but nothing to their brain? It's kind of a difficult conversation to have, but I think we need to be transparent in what we're doing. Where I come from in the United States, I think with the rocky political situation we're in, there's a lot of distrust now around the organ transplant system. And there's been a lot of sensationalized stories of, you hear, this patient was brought to the operating room to donate their organs and then they woke up, which is not necessarily exactly what happens, but that's what gets reported in the news and what people read, in which case they take themselves off organ donor registries and they're afraid to consent for their loved ones to have the same procedure. So I think we need to be open and upfront with what our plans are, but we can do a better job explaining to a family what NRP actually entails and what it means for not only getting the best use out of their loved one's organs, but also making sure that the people we transplanted in have the best chance of having a healthy and good outcome. And then finally, the sort of family dynamic. When and how does a family get to say goodbye? At least for VGH in our NRP protocol, we do everything in the operating room just because we're simultaneously doing a study about perfusion to the brain to make sure it's not actually occurring on the ECMO circuit. And that requires a lot of intensive neuromonitoring. So a lot of it just has to happen in the operating room. But we basically set everything up like we're going to do the operation. All the equipment is draped so the patient's family doesn't see it. They come in with the patient on the operating room table. Life supporting care is withdrawn. Patient hopefully expires. The recovery team is usually 2 or 3 doors down watching the vital signs on an additional monitor. And then after the patient expires, while the 5-minute waiting time is happening, the family is quickly ushered out. And it's so quick that they literally get ushered out because we, as the recovery team, can't really interact with them as an ethical barrier. But I can imagine it's maybe a bit awkward. You're with your family member as they die, and then all of a sudden they say, okay, your time with them is up, you need to leave. So again, it's a conversation that definitely needs to happen about what the protocol would be after you consent for your loved one to undergo organ donation, and everyone just has to be on board that that's exactly what's happening. And then finally, the ethical considerations of NRP is kind of the hot button issue surrounding this technology. So in transplantation, we have something called the dead donor rule, which is a very simple rule. That is, we only take organs out of someone that is dead unless they consent to it. So the sort of traditional paradigm was that you are dead if you have no circulation, but if you're artificially restoring circulation, are you reversing that dead donor rule? Secondly, is blood flow to the brain restored with NRP? I think it's very unlikely, but no one's ever done an actual study to show that if you just cut or clamp off the thoracic aorta or tie off the great vessels to the brain, are we sure that there's no other blood flow to the brain with things like spinal cord collateralization? That's actually what VGH is doing now. We do neuromonitoring and EEGs during our actual donation process and during the NRP to make sure that there's no potentiation in the brain. And I think that's going to be, I think they're aiming for about 10 and we're up to 6 to, definitively put it to bed that NRP is safe and we're not restoring blood flow to the brain. And then what does it actually mean if, God forbid, there was cerebral blood flow after someone has died? I think, again, it's highly unlikely. 5 minutes of anoxia to your brain is devastating, but there's, I guess, the potential for things like potentiating pain. I don't think there's going to be awareness, but any blood flow to the brain is certainly detrimental after this has happened. Is NRP and DCD donation going to disproportionately affect stigmatized patient populations that are already burdened by things like substance abuse? A lot of DCD donors, unfortunately, are the result of drug overdoses. Again, the donor, recipient, family members needing to be aware of what DCD donation and NRP involves, being transparent with how we communicate these things to patients. And if we don't, and patients understand or learn later on, or their families learn later on exactly what we did to their loved one, then we've eroded trust in the healthcare system and in transplantation as a whole. And then finally, as we talked a little bit about it, but alternatives to perfusing organs in the body is perfusing the body outside the donor. And that kind of gets along the barrier of, you're only perfusing a liver, you're only perfusing a kidney, you're not perfusing the whole person. But again, these are all things that are associated with significant cost increases and different outcomes. So ongoing discussions need to be had regarding NRP. I'm personally very excited about it. I think it's kind of a game changer in terms of what we're able to do for transplantation as a whole. And hopefully as I sort of graduate and move on from here, it's something that I can incorporate into my practice, whether it's something that has already been established or maybe even we can start up when I get my first job. For us specifically here in BC, we started NRPs last year in 2024. We've had 5 donors actually undergo the procedure. 1 didn't pass in time, so we just canceled the case. Of those 5, 4 livers ended up being transplanted, 10 kidneys were recovered. We did 1 pancreas, in which case we did an islet cell transplant as opposed to whole pancreas transplant. We're doing 1 this morning at 8:30. And then again, we added neuromonitoring as part of a clinical trial or clinical study to assure that no cerebral blood flow is actually happening during the process. And then this is kind of where we are in terms of the whole system getting up and running. We've kind of gone over all these barriers, and now we're here with a slow start, hopefully doing more and more each year.
Andrew, quick question.
Sure.
You mentioned 5 patients, that only 4 livers. Was that because when the NRP protocol was done, you decided that no, but otherwise, if there was no NRP, this would have been yes?
Yeah, so the first liver, or the first case that we did NRP on ever here at VGH, it actually went through. We looked at the liver and we're like, this is a bad liver. We're not going to take it. This is just like, we're going to get the process going. We'll take a look at it and see how it does. We'll get NRP moving. We'll actually cannulate and put the organs on the ECMO circuit and see how they do. But like based on the LFTs and how the patient looked and what the liver looked like on imaging, we're like, there's no way we're going to take this. And then we opened up and we're like, oh, this looks pretty good. So we didn't have like a recipient that was ready to go like in the next 2 hours to actually do it. So that liver was like a situation where we actually could have recovered and increased our liver numbers, or at least seen how it did over 2 hours on the pump, whether it made bile or the LFTs cleared or lactate cleared. But that one was just literally the first one we ever did. And we kind of were speculating that, oh, the liver's not going to look good. But we got in there, we're like, oh, maybe we could have actually done it. But the other 4 after that, it was the same thing. A few of them looked maybe marginal on paper, and then we actually did the NRP, and you can see that the liver looks good. It's nice and smooth. There's no bumpiness. There's no cirrhosis. We do routine liver biopsies, so we have the adjunct of the pathologist telling us the degree of steatohepatitis, whether there's any fibrosis present, and then over time we collect and monitor how much bile the liver's making, and we're like, oh, it's making bile. Biopsy looks good. It might not be the Cadillac of livers, but it's a Toyota of livers. It'll work. So we transplant it. That's right. Any other questions? These are just some of the highlights of my fellowship so far. I think this looks like kind of like a Renaissance painting with Blazinski looking over us, doing a donor. This is an NRP donor here. You can see the cannulas on the bottom. It's maybe a little bit hard to tell. It's a bit dark, but one is clearly darker. That's the venous IVC cannula, and this is the oxygenated aorta cannula. This is our little cup collecting bile. Goes up under the liver into the bile duct, and then you can see the liver is nice and brown, homogeneous, looks normal. And then this is the aorta cross clamp, so that everything below the cross clamp is perfused, everything above it is not, and the lungs have been taken out for their own transplant. And then this is a nice little kidney that we buckled in.